Hi guys, I'm Maylin Dovan, certified athletic therapist and founder of Rehab-U Movement and Performance Therapy. I'm with Joey Russo from Fast Strong Kinesiology, and we're going to talk about externally paced training for tendinopathy. So if any of you have dealt with tendinopathy before, you know that rehab outcomes vary. There's no common protocol, there's no best proven protocol for tendinopathy. What has been proposed is that there are changes in motor control associated with the constant and persistent pain of tendinopathy, which means there are neural adaptations in the way we move to move outside of painful ranges. So essentially that's the pain adaptation model. So the body changes the way it moves because there's pain that's associated with specific movement. Now, we rehab tendinopathy using different parameters, namely often using isometrics and eccentrics, but because the outcomes of recurrence of tendinopathy vary a lot of people end up with a recurrent bout of tendinopathy, patellofemoral tendinopathy, for example. What we're thinking is that this may be because just doing isometric and eccentric exercise doesn't have an effect on that motor control component or that neural adaptation that occurs because of the persistent pain of tendinopathy. So there's what we call cortical inhibition that results from the persistent pain of tendinopathy, and standard rehab protocols don't really address that, or that's what's being proposed. What's being explored to treat tendinopathy and treat that cortical inhibition aspect of tendinopathy and that changes in neural and motor control is neuroplastic training. So tendon neuroplastic training, namely using externally paced exercise. So a lot of studies have compared regular resistance exercise where you set your own pace, or whether you're given a tempo but you set that tempo yourself, versus externally paced tempo, for example, using a metronome. And these studies have shown that there was a decrease in cortical inhibition. So it is being proposed that using externally paced exercise can help with the rehab process of tendinopathy because now we address the motor control component, okay? So externally paced exercise, essentially what that means is that I have a tempo to respect for my exercise, but it's a visual or audio external pace. So using a metronome would work, using a visual would work as well. But it's not me counting my eccentric and concentric contraction, it's an external pace, okay? The way I deal myself with tendinopathy, obviously you've heard me mention in a previous capsule that the most important part of dealing with tendinopathy is load management. So we're always stuck in a little bit of a battle between protect and expose the tendon. So as much as we need to protect it from exercises that are too offending and that will easily surpass the load tolerance of the tendon, if we underload it too much, then we've got that much more gap to cover before getting back to optimal performance. So in your management of what you do, what exercises you choose to modify or change, you're gonna have to consider what exercise surpass that tendon's capacity and what exercise don't that I can load so that you ensure that you don't underload the tendon. So strength in the continuum of care is one of the visions of Rehab-U. Rehab is training. So how do I keep loading that tendon but making sure that I don't surpass its tolerance? So if we take the example of patellofemoral tendinopathy, then certainly in a portion of my rehab process, for example, in my activation phase, I certainly would have a low load exercise that stresses the tendon in a more lengthened position. But in my integration phase, which is partially about how I continue to load my tissues, I would select exercises that don't bring me into a range that will irritate the tendon so that I can load, okay? So it may be as simple as saying, well, right now, you're not gonna do any front squats, you're gonna use low bar back squats, or box squats, or a variation of the squat that's more hip dominant, has less torque at the knee, is less offending for the patellofemoral tendon, and will allow me still to load, okay? That said, again, in the activation phase, I do want something where I work that knee past the toes position, okay? Because the patellofemoral tendon needs that capacity and I've got to slowly work my way there. So what I might use as a rehab exercise is a step down, and what I would use in my integration phase is, for example, a back squat instead of a front squat because there'll be less torque at the knee. That said, for both of those exercises, I'm going to throw in a regimen of externally paced tempos, okay? So what I use is an application that you can download called Simple Metronome, and that you can set the beats every 4 seconds. So if I want him to do a 4-second eccentric, 4-second concentric, then I can set it that way, and he has the visual and the verbal cue, okay? The step down exercise, it's a patellofemoral rehab classic, okay? But it's a good way of continuing to bring that tendon into a lengthened position, have that tension on the tendon, but in a load that's manageable and tolerable for the patient, okay? So he's got one foot on the step or plate, and he's bringing the other foot down to touch the ground. I'm going to start the metronome after. Now what I'm going to ask him to do is actually bring that foot right by the other foot, so straight down here. So he's getting that knee towards the toes movement that we want to build tolerance for. And then to make it externally paced, I would start the metronome for him. Can you guys hear that? And he's going to go to the beat of the metronome. 4, up, 1, 2, 3, 4. Good. All right. So this little guy is really interesting because you have the audio cue, and if it's loud in the gym, he's got a visual cue where every 4th beat will be pink, and that's when he reverses. All right. And then essentially in the integration phase, whatever exercises we've given him that he can load, we're going to use the same process. So he's going to go into his back squat. And once he's ready, he'll start good. Perfect. All right, so you guys are starting to see the pattern. So what am I doing in my mobilization phase? Whatever I need to do as far as creating space. So classics, for example, if we take our patellar tendinopathy example, patellofemoral tendinopathy, oftentimes there's some release to be had in potentially the quads. There may be some soft tissue release things to do there. That might go in the mobilization phase. In the activation phase, in this case, I'd be doing stuff like step downs, or stuff where I'm letting the knee go towards the toes in a range that's tolerable for the patient, externally pace applied. And then in the integration phase, what exercises can I choose so that I continue to expose that tendon to load without surpassing its load capacity, and then throwing in externally paced as well. So I would keep that externally paced exercise for all of my first phase, for the full 4 weeks of my first phase of rehab. As far as sets and reps, what you might use, activation for something like the step down, You do want to get some endurance, so I would go higher rep range, 12, 15, maybe up to 20 reps with the external pace. Whatever I do for load, I would continue to work within the parameters of where my client is. So if I'm trying to, maybe in the first phase, I want to stay more within hypertrophy ranges because I'm trying to create strength in the structure, then I would use a hypertrophy rep and set parameter, okay? But externally paced all the time. So hopefully that helps clear up some views on how to deal with patellofemoral or other areas tendinopathies.